we have a great day. So welcome. I think we're going to start with some quick introductions. And we have my two other co-panelists here, Valencia Robinson and Liz Salmi. So my name is Andrea Downing. I am the co-founder and board president of the Light Collective. We're going to be talking today about the Patient AI Rights Initiative. As a person with a BRCA1 mutation and a background in technology, I am combining and working towards our mission to advance the rights, interests, and voices of patient communities in health technology. Over to you, Liz.
Hey, everybody. Nice to meet those who I haven't met before. I'm Liz Salmi. I'm a person living with a malignant brain tumor for nearly 17 years. Wow, it's a long time to stay alive with this condition. I am as a patient advocate, I am the co-founder of the hashtag Brain Tumor Social Media, or BTSM community on Twitter, which I was one of the co-leaders, co-founders of for more than a decade. And that work ultimately resulted in collaborations with clinicians and researchers. And then that turned into patient co-authored publications in journals like JMIR, the Journal of Palliative Medicine, Annals of Behavioral Medicine, the Journal of Neurosurgery. I'm just like listing everything. And then my first ever patient first authored publication in the Journal of Neuro-Oncology Practice. And, you know, that's a long thing, from diagnosis to social media to now publishing stuff. And that ultimately brought me to my role that I do today with Open Notes at Beth Israel Deaconess Medical Center, where I'm our communications and patient initiatives director. And today I really take all that patient experience and inspiration to blend my brand of community organizing to patient partnered research. Handing it over to Valencia.
Hello, everyone. I am Valencia Robinson. I'm an 11th grade English teacher. Tomorrow is the last day of school, and I'm a proud 18-year survivor of breast cancer. I was diagnosed as a high school English teacher, and my kids were 3, 4, 5, and 8. So fast forward, now I work with the Light Collective as a founding member of the organization. I serve on the boards of the Florida Breast Cancer Foundation, the National Breast Cancer Coalition, because really being African American, I bring a unique and necessary perspective. You know, I have a strong family history of breast cancer. My sister was diagnosed. My aunt was diagnosed, and she passed away of metastatic breast cancer. And I was very young when I was diagnosed, had an aggressive subtype, but I had to navigate my way through it, right? There was no social media, there were no groups. It was just little me trying to figure out the best plan of action and to learn the things I've had to learn. So that really has given me great insights that are crucial for shaping effective advocacy and social support initiatives. And my role within the Light Collective really is to unite all patient communities. Since I've been involved in so many different grassroots organizations, so we're just trying to align with their mission and goals while educating them on fundamental digital rights, and now that encompasses AI. Andrea?
All right, so we'll get it started here. And I'm going to share our screen and just go through a quick presentation for about 12 minutes on what we're doing. And we're very thankful to you, Mark, and Health AI Partnership for having us today to talk about the Patient AI Rights Initiative. So let me go ahead and share my screen and let me know if everybody can see this. Are we good?
Yes.
All right. So, topic, patient community wisdom. When we think about past waves of technology washing over us, this isn't our first rodeo, and we want to share some of the wisdom from past waves of technology and innovation as we build this future of health AI together. So we gave our introductions, very glad to be here. The Patient AI Rights Initiative is something that we're really proud to share with this community and to think about future partnerships as we carry this work forward. But I'm going to start with why we began this work and why the Light Collective exists. So I mentioned in the beginning, we are a patient-led organization, and our mission is to advance collective rights, interests, and voices of patient communities in healthcare technology. One of our guiding principles is no aggregation without representation. And this picture you see is really a special and important picture to us. It was at our first meeting in 2019. We brought community leaders together in DC because we saw a deep and urgent problem, and nobody was coming to save us. So here's the backstory. In 2018, after Cambridge Analytica, I started doing some research and applying my background in technology to ask a simple question. If we could scrape profiles from Facebook to think about creating predictive or behavioral models to target people of different identities and use that to serve people content or even manipulate behavior, what were the implications for support groups? Now, you have to keep in mind that in the early days of social media, going online was a magical place. You know, back in 2008, Facebook was the privacy aware alternative to MySpace, and everybody was flocking to this incredible, wonderful network. We were flocking to Twitter, and there were these high ideals of how social media was going to democratize the internet. And there were really great things that happened in those early days, including our communities being able to find each other, to organize, and to develop communities that were vital lifelines for not only social support, but research. But there was a catch. And roughly around 2017, 2018, we started seeing something different happen. You know, these platforms started to get monetized. And I want to point to, and by the way, all of these slides we will have posted on our blog. So if you want to refer to any of the links, the references, or the citations, you can go back to these. But, you know, we started to see how pharma ads were being targeted to patient communities in ways that we hadn't seen before. And here are just some examples from the cancer community for, you know, ads that we would receive. But we started to get frustrated with this because it became more and more aggressive. But not only did it become more aggressive, we started seeing snake oil, things like ivermectin or black salve treatment that, you know, if served up to or, you know, bought by people in our community could literally like rot off our skin. So the question became, well, how is this happening and why? In 2022, so there's a whole backstory I won't get into about us uncovering that flaw. You can go back to that CNN story in the early formation of the Light Collective. You know, there was a whole FTC complaint and a vulnerability that allowed any attacker to scrape all closed groups on Facebook and attach it to a fact about a member of a group with strict inclusion criteria. And if done, that could be attached to their physical location, their email, their phone number, and the health fact. We went on to do this research where our first peer-reviewed study was published in 2022 in partnership with the former chief scientific officer at Duke's, chief scientific officer of Duke Digital Health. I think you guys know, many of you at Duke know Eric Paraxlis. He's been an incredible mentor. And I want to also thank Liz because around this time, she had published this piece in New England Journal of Medicine. And we thought, let's start publishing stuff. Let's start developing evidence and learning how to build a body of evidence around a problem we're seeing and an unmet need. So in this, you're seeing two snapshots. Over here on the left, you see a genomic testing company. We started looking at the tools they were using initially for CRM and marketing, but some of these tools were using AI, you know, some really scary stuff where, you know, you could merge all of your data across different social media platforms and combine it with other things where these were black boxes. We didn't know how we were being targeted, but it was all for the sake of marketing, right? We have to keep in mind that outside the walls of a HIPAA covered entity, up until 2023, there were very little protections, and the health breach notification rule from the FTC had never been enforced. We brought this story to the markup in 2022, and the follow-up investigation showed that 30 of the top 100 hospitals were leaking data from patient portals, authenticated patient portals, including appointments, physician names, conditions, all kinds of stuff. And that soon led, well, unfortunately, the markup didn't cite us in the original story. We're very glad that the research and body of evidence that came out of this led to a definitive ban on tracking technologies from both the Federal Trade Commission and Health and Human Services. We're now in this wave of federal and state class action lawsuits, and what I just shared with you was the middle of one wave, where there was a wave before that and a wave we're in now. The wave before that, back in 2005, when I tested positive for a BRCA1 mutation, my doctors told me I had cancer in my future. And what that meant was I took a genetic test that was very hard to access that told me I had up to an 87% chance of developing breast cancer and up to a 60% chance of developing ovarian cancer in my lifetime. But it turns out the company that did the diagnostic test had a patent on BRCA1 and 2. And there was a case that went all the way to the Supreme Court on whether human genes could be patented. As a spokesperson for one of the plaintiffs in the case, I was astonished at this one fact. Before AMP versus Myriad, 40% of the human genome had been patented. After this case, it opened up more affordable diagnostic tests in new ways that allowed for better therapies, better and more effective diagnostics, and a more efficient market. So I went back to the first wave. There's the middle wave we talked about with Cambridge Analytica, but where does this leave us now? We're now in this wave where we're seeing increasing ransomware attacks across health systems. For anybody on this call who is in health policy, cybersecurity, or working with a health system, you've probably heard about the Change ransomware attack or what's unfolding with Ascension across multiple states. You also probably heard about the hack with 23andMe. We sat in those boardrooms in early 2022 when we were talking about this first wave of how genetics was going to cure cancer by 2024. And I'm still looking at my watch, but what we got instead was a data breach affecting 6.9 million users and targeting people based on their genetic heritage. I also want to point out that we're in this place where some of the same companies that are developing predictive algorithms, especially within the payer side, are using these data in order to charge us the most amount of money for the least amount of care, or even deny us care in the ways that cost us lives. So we're in an increasingly hostile environment. And what we're trying to do is ask ourselves, okay, within this new wave of AI that's actually been around for a few years, but now it's exploding. We're getting all of these companies coming and researchers coming to us and saying, okay, let's partner. And we want the good data sharing. We want better cures. We want safer outcomes, better health outcomes for our community. But we've learned over time that we have to be a voice in this conversation in a way that carries forward representation of communities, not just as research subjects, not just as focus groups, but as true partners on equal footing. We're very proud of our progress. We've, at this point, competed at DEF CON 5 times. You'll see some pictures on Valencia and I and our team at DEF CON. We have worked with a patient AI rights initiative with the National Academy of Medicine. We have done a ton of stuff. We are very proud to partner with Dr. Maya Rocky Moore Cummings, the widow of Elijah Cummings, who believes some of these issues in digital rights are impacting some of the most important civil rights issues in our generation. And really, this is about human rights. So I encourage you to check out more about the Patient AI Rights Initiative at lightcollective.org. You can go there and you can see the banner where to get to our rights. I also encourage you to read the stories of each and every patient who came to this initiative and their incredible experience and background. The timeline for this project, we put it together pretty quickly because we were starting to get pulled into rooms, each of us within that last slide, as individuals asking for our input or our advice representing all patients on policy. And we started to realize we need to come together as a patient community, even though we may not always agree, and that's okay. We have diversity in voices and opinions, and we need a forum to learn together. So we began our ramp up in December of 2023. We are now at a place where we have opened up the draft that we created for public comment that closed for public comment on May 8th. And we are merging the comments that we got from patient communities and stakeholders with the goal of giving our final report and a town hall, which we invite you to on June 26th. These are the 7 rights. I'm not going to go into detail on all 7. You can read all about this on the Patient AI Rights Initiative, but there's a central theme here. One of these themes is we need independent duty to patients. When we say that, we live in this world where AI is making decisions about us without us. And in this world where life or death decisions can be made largely by companies or health systems that have a fiduciary role to shareholders and not a primary fiduciary or legal role to patients, there needs to be a layer of independence and governance that serves patient communities first. So when we think about transparency, self-determination, or our right to make informed medical decisions and be empowered by the data that should work for us and not against us, these choices should be our own, and AI should be used and designed in a way that helps us improve outcomes. I also want to point out when it comes to privacy and security and thinking about the increasingly hostile environment we're in, you know, I never imagined that I'd be thrown into this world, nor should I be here. If we could, fully trust that all the policymakers and health systems out there just have it covered, we wouldn't be in this place where we have increasingly dangerous digital environments that are attacking our unarmed communities in ways that we never imagined. I also want to point out one thing, which is a lot of folks on this call, you can change your jobs, you can change your institution, you can change or even have a company that you are acquired in. We cannot change our identity. We can't change our genomes. We can't change the communities that we exist in. And therefore, when we think about our human rights and these waves of technology that wash over us over and over again, let's really take a step back and a moment to start thinking differently about the current really bad state of healthcare and how we get patients real enforceable rights. I'm going to go through this really quickly. This is how we put up our comments on GitHub, or our draft on GitHub, some of the ways we got public comments. Last thing I want to say is, for those of you who are new to partnering with patient communities, welcome. We are so glad to have you. And there's a whole body of research and evidence out there from the Patient-Centered Outcomes Research Institute on foundational expectations for partnership. I encourage you to go check out this resource, but also look at the body of evidence behind partnering with patient communities in order to create more effective research, more effective clinical trials. When you partner with a community early, often make sure your community partners are diverse, and empower that community to lead, make decisions, and co-create the outcomes. You will be in a better place in ways that you never imagined. The last thing I want to say is, never doubt that a small group of thoughtful, committed citizens can change the world. Today, we live in a world where patients are subjects. We're no longer interested in being part of focus groups or just being given a survey to see how we feel about trust, we have a different view of trust. You know, if you look at those examples or those data points, trust is how we look to the past, look at the data that we have on how technology can be trustworthy in order to predict the future of how AI is going to shape our world. And due to the transformative nature of AI, we have to do something differently. Thank you. And now we will open up to questions.
Thank you so much for sharing that important work. And we're so excited to have you. We will start with a panel discussion. We have a few questions for you all, and then we can open it up for the audience members to ask questions. People can also post questions in the chat in the meantime. So my first question is for you, Liz. Thank you so much for joining us today. There are lots of stakeholders putting their voices forward around like how AI should be governed. There are like health systems saying things, there are regulators saying things, and industry partners saying things. Why is it important to establish patient representation and voices in the design and governance of health AI?
That's a great question. And I love that Andrea really answered that point by point and also talked about, and she provided some citations there about how this work is already being done. And so she laid out this case that we're advocating for the creation of an independent patient-led governance body for health technology, which has never been done before. This body is going to be defining digital rights for health AI and collaborating with regulatory authorities and stakeholders to enforce these rights. This is radical and it needs to happen. Andrea really outlined that there exists this ecosystem of digital health technologies, from hospital portals to search engines to apps and online support groups, that are vital for patient communities. However, the same ecosystem can expose us to privacy breaches, illegal data sharing, exploitation of some of our health conditions, disinformation, misinformation, fraud, and then other harms, which the Light Collective has described as cyber harms. Love that term. As patient communities, these technologies, even within the secure HIPAA-covered entities, such as like MyChart, they can be broken out, that information, and like that creates new potentials for harms. And so these patient communities that have been developed over these years as a benefit of the internet is that we really don't have a voice in the deployment of how that information is used and shared. And then there's also profits to be made based off of that concept. So what we're pointing out here, long way of saying, what we're pointing out here is there are more patient users of these health technologies, and we really need a voice in how this is governed. And the Light Collective is stepping up to be that voice. And it's a collective. That's a really purposeful term, Light Collective, which means that organizations like the Health AI Partnerships can join that effort and really sign on and look at these rights that have been created. And by the end of this meeting, members of this partnership could decide to partner with the Light Collective by adopting the AI rights for patients.
Thank you so much for that answer. So my next question is for you, Valencia. You do a lot of work with community outreach and bringing people together. As you were mentioning, Andrea, a lot of people try to send out surveys and ask about like how patients are feeling. But what are some meaningful ways to how do we fairly partner with patients when developing health AI?
Well, I really think the very important question, and the most important step, is to engage a diverse group of patients, right? These patients must represent different demographics, medical conditions, backgrounds, to ensure that AI addresses a wide range of needs and perspectives. You know, it's funny that in the work that we do, they're so few people of color. And I'm not the spokesperson for all African-American women, right? So we gotta have different demographics. We gotta have different medical conditions. And we gotta have patients from underrepresented, unsupported, and marginalized communities. That is a key thing. And I know people say, well, they may not know, but people can learn. People can learn. I'm an educator. I had to learn how to navigate through my cancer diagnosis, and we can learn the things we need to learn. We can be taught what we need to be taught, right? And then patients need to have things in understandable information, right? It needs to be at a language that patients can really grasp. If this is new to them, they need to be able to grasp. They need to know the potential benefits. They need to know the risk of the AI. We need to maintain open lines of communication with patients all throughout the development process. And everything that we say matters. I mean, industry may not think it matters, but it has to be continuously integrated, the voices of the patients. And that's a good start right there.
Thank you. Thank you so much for that answer. We'll go ahead and move on to next question for Andrea. What have you learned from the Patient Rights Initiative so far? So the work that you've been doing, what are some of the meaningful learnings that you can share from it?
Well, I know that, so just a quick note, Liz has to drop off in like 2 minutes. Liz, I mean, you said some of the most like important insights to me. Everybody on this project taught us, like, we weren't expecting some of the things that we learned when we got these diverse voices together. So you really hit it home a few times, Liz. Would you answer this first and then I'll riff?
Yeah, I'm hoping I'm answering the direct question, because I tend to just like meander off.
Yeah.
But the things I've learned from this work is, or that I think everyone else should learn from this work is, none of us can speak on behalf of all patients. There's not one patient. By the way, this group, if you look at the list of the cast of characters who worked on this document and led it through, and thanks to the Gordon Betty Moore Foundation for funding this, is we do not agree with each other. We absolutely do not agree with each other. I can point out pictures of people on that group photo of like, I don't agree with them, but oh, this person, yeah. And so it was like this match, what you see, what is the result of this is stuff that we're like, but this exists across communities. And this is like the message we're trying to share. And why it's important to bring in, if you're a technology organization or you're like an academic health system, like, you must create, feel free to partner with the Light Collective, but work within your own systems. If you're I know for a period of time, Chris Longhurst is here on this call from UC San Diego Health. Like, different health systems have opportunities to engage patients through your patient family advisory councils. Like, these things already exist. And then there are things like funding opportunities, like the PCORI model of patient engagement. It's not about lip service. It's actually co-designing your product or your study in partnership with your patient voices all along the way, where it's not like, oh, we just want that person to kind of bless the logo for this project. No, it's like, what is the research that's meaningful to these individuals? And as we move into the future, how AI is used in research is super important. I just read this really great paper that came out of UC San Diego, specifically about using AI to analyze MyChart messages. And then in the paper, it does direct quotes from what patients said in their MyChart message in the paper. And I thought, wow, this is really important. But also, did that patient who you directly quoted from the MyChart message know that their quote was going to appear in an academic paper that's open access? That would be a great question to bring back to your actual patient family advisor council about how AI should be used in research and other stuff. So that's kind of like a little bit of a rant, but also I wanted to answer that question.
Thank you, Liz. And I know you have to go. I want to point out something else that it was an insight that you kind of said and it sunk in, which is, well, yeah, of course, we have a diversity in opinions and backgrounds. Guess who else does? Scientists.
Absolutely. Yeah, I'll agree.
If-
And that's what makes this these debates so exciting. Like that's like if we all agreed, then why are we here?
And there seems to be this fear. We got like in the beginning, this like pushback where it's like, oh, but how are we going to get all patients to agree? And that's not the point. The point is we have to build capacity as equal partners with institutional support on equal footing to understand what the threat models are, how this technology can be designed with real world use cases and problems that our communities have to solve, not just what's in it for the next grant, how do where's the hockey stick with VC backed funding? Like we got to pull it back. And we got to do it now because AI is really ramping up, and as we do that, we're not all going to agree. Not everybody on this call agrees on how we move forward in this uncertain world because we don't know what the future holds. We just know that if we don't put our voices on equal footing and establish the patient voice in making the rules, what is going to start to happen is already happening now. I can refer to you. I was just quoted in Stat yesterday about how there are efforts to ensure that AI, especially from payers, are when we have proprietary algorithms making decisions about patients getting rehab or benefits and care, automated denials of that. There are already class action lawsuits about that. And I'll cite Cigna and United Health, where they're really trying to get to the point where policy would enable that. And we've seen this over and over again in genetics and like the Myriad patent case. Like that's not going to work, and it's just not good medicine. It's not good science. We need transparency, reproducibility, but also rights and partnership on equal footing. So that was the question.
Thank you so much. That was awesome discussion. And I think it leads well to my next question. And a little bit that you already answered, but I'll still go ahead and maybe fine point it. So what concrete steps health delivery settings can take to ensure that the patient rights, that they're engaging patients, they're understanding what they need, what their concerns are, that those concerns are actually integrated and acted upon as AI tools are built and integrated into clinical care. And if you've seen any good examples or bad examples, that'd be great too.
Yeah, so I will take the concrete steps, but let's talk about why the concrete steps need to happen soon. Yeah. And Valencia, can you share a bit more about what's happening right now with approaching communities, especially vulnerable or diverse communities when it comes to AI?
Well, what happens is we are asked to join, say, a group, right? And then well, I'm gonna say it as plainly as it happens. So they'll pick an organization, a Black-led organization, where that person has a lot of standing in the African-American community, right? So they'll go to that person and tell them whatever. We need you guys to sign up. We need you guys to be a part of this, whatever. But so I always push back. We had another African-American young lady on our board, Tia Tomlin. We would always push back because we were working with the Light Collective. We knew the questions to ask the different organizations that were trying to basically get our data, right? And they're making money off of our data, but yet they want us to just really give whatever they're asking. And if people are not careful, and if they don't understand all of the processes of, their information, then that's once you put your information out there, it's no taking it back. So that's why patients need to really be educated on this. We need to know all the details, and the companies need to make sure the patients fully understand how their data will be used, how it will be stored, how it will be shared, and they need to gain explicit consent, right? And then when these consent agreements change, people need to know, people need to be advised. And that wasn't happening. But because another young lady and I were a part of this work, and we are founding members of the Light Collective. We've been there since the very first Robert Wood Johnson funded grant. So we know, and our job has been educating all communities, all patients, as many as we can reach. And that's just what we will continue to do, because there's so many things that can happen if patients do not know.
So I want to tag on to this. Two key things are happening right now in what Valencia described. The ask to patient communities is, we'll go to a grassroots organization that has a huge following on social media or a patient registry and say, hey, recruit your community, but there's no question of how we're signing away our rights. What happens when that company gets acquired? What are the downstream impacts or effects? Where, going back to, we cannot change our genomes, we cannot change our identity, but everybody else, no matter how ideal we think in the early terms of, or in the early stages of a technology, we're going to be there 10 years later when we're left with a bill if things go wrong. So back to your question, Alifia, what are the concrete things? We shared, so the PCORI, I know I'm a professor here, but I'm assigning homework. I would encourage everybody to read the foundational expectations for partnership. We've done this in clinical trials. I want to point out, the metastatic breast cancer community that we work with has changed the game in diversity of clinical trials. When there's strong partnerships, established norms, and knowledge of what the best practices are in order to partner with a patient community early and often, there's so much potential for what we can achieve with AI. And believe me, we're there. We know that AI is a truly transformative technology and can bring about some of the most amazing things that we have been waiting for decades. But in order to get there, the first concrete thing, do your homework. So I assigned you homework. The second concrete thing is we're working to take this first draft of the AI rights initiative. And I want to thank Mark, because when we announced this, the question wasn't, okay, what can patients do for Health AI Partnership? Was, what can Health AI Partnership do for patients? So flipping that script. And, we started thinking about, okay, how could we take these rights and move it forward to the next step, to quality measurement outcomes, or methods where the strength of partnering with researchers is, I don't necessarily want to do that with my full-time job. I just know what the priorities are, and I want to take the priorities for how we would measure outcomes in the AI life cycle in order to impact communities and find ways to do this in a real clinical setting. So that would be the second concrete step. Mark, you have your hand raised.
So it's been such a pleasure getting to know you both, Andrea and Valencia. I know that when I started talking with you 5-6 months ago, there's a little bit of like a coming to Jesus moment where you're like, yeah, I've been working in this space for a while. I know that there's problems here with how the work is done. Most people don't fully understand. You guys clearly understand, and you're pointing things out. But this is an uncomfortable space for a lot of health systems. I don't know if you intentionally clipped the list of sites from the markup, but I know that Duke was on that list. I know that Duke had lawsuits from patients who were suing because Duke had the Meta pixel on our hospital website. You are clearly not the Department of Justice. It's not like you're trying to come in saying the people on this call have done something wrong. You're trying to start a conversation. But given that I know that this is an uncomfortable conversation for a lot of health systems, how would you advise, and I know that you just gave the homework, so maybe you've already answered the question, but like, the easiest thing to do is do nothing. The easiest thing to do is just to continue doing the work the way that it's done now, where there's no transparency and very little accountability. But for folks who are scared to start this engagement, what do you have to say to them?
AI is different from past ways of technology because of its transformative nature. These waves and hope and harm are going to start happening faster. And so what I want everybody to know on this call, and let me just point out this dynamic, like when we look at the pixel tracking research, I want to point out my co-author on that paper was from Duke, and you're from Duke. We have our approach. We're embracing people. We understand that there's no, oh, Duke is evil, we don't want to talk to them. At the end of the day, we're all humans trying to do the right thing and build a future together. And, we also understand that researchers and health systems are out there struggling in ways that we want to help solve, because of the structural things or the machinery of the way the health system works, whether you're in the US or in a single payer system in another country. There's always going to be good and bad. The only way we can get past that is to really start seeing when an adverse event or harm happens in our communities, we start to see it first. And when we start to see it first, we have to go somewhere to do something about it. I have this joke in, again, having gotten to the point where I have spoken at DEF CON and I've navigated security vulnerability disclosures with some major companies. There's a sense that this truly takes a village. We're not out here to, take down people. We're out there to think about the structural inequities and how we can fix them together. I hope that answers your question. I don't know if that's enough or tangible enough, but I don't want to people are, I think, that idea that we're not the Department of Justice. No, we're not. What we don't want to happen is what happened with the pixel tracking example as a case study. So when you think about that wave of us doing the research in 2022, by the end of 2022, there was a ban, and now there's a wave of federal and state class action lawsuits. The way we could have gotten ahead of that was back in 2018. If people had started listening to what we were saying and partnering with us, we wouldn't be in that place where it took us 5 years and it got so bad that we were targeting people with snake oil for years. And we asked about, one of the big questions we had in the questions was, what about medical misinformation? So we characterize patient communities as going on social media and being left in themselves and they're going crazy. No, it's the structural ways that we're targeting these communities with really harmful content And we need to stop blaming the patient or the community and start thinking about how the incentives to monetize with AI and ad tech, or with, you know, the pixels that were leaking data of our health conditions in the first place happened. It happened because marketing teams were not talking to the security teams or compliance teams in health systems. So let's figure out how to bridge this gap, because our incentive here is, again, we have our lives on the line. We're not here to like vilify people. We're here to survive. That's really the stakes for us.
Thank you for that awesome insight and the discussion too. One last question, and then I'll move on to the questions from the audience. How is this work different from other AI policy initiatives and frameworks?
That's a great question. So I think, first of all, I want to thank, so I don't think anybody, maybe some people from the National Academy of Medicine work groups are on this call. And if so, I just want to share, you know, the incredible learning and collaboration, and shout out to Laura Adams. She partnered with us early and often. And what's interesting is, you know, we're learning a lot about how codes of conduct get made. And there's, you know, going back to our central thesis within our rights initiative, there's this push right now to say that we can have like one company and one code of conduct within that company, and they can like self-regulate. But we've seen so many AI safety teams disband, like, you know, OpenAI just disbanded their safety team, when again, the independent governance from a third party doesn't happen, or if we don't have reproducibility to show that, you know, AI in its deployment and specific use cases for a specific community are safe, just like a device or a medication would be safe, then we probably shouldn't be deploying that on a patient population, number one. But number two, another thing would be really taking a step back and saying, you know, think about my story and that fundamental human right to have good evidence, good science, good diagnostics. And in the early days, our community not having access to that because our genes were patented. You know, so that is really kind of the lens that we look through in a different way. And that different lens can open up opportunities. If you think about the gene patent case, imagine what would have happened if 40% of the human genome were now like 90 or 100% of the human genome. What would that mean for cancer research, targeted therapies, and this entire industry? You know, so playing the long game, thinking not about the short outcome for your grant or your company. You know, think of us as a community, or a place that we exist. Even though we're in digital spaces, we have to care for our digital selves and digital spaces for the long term.
Thank you. I'll open up for questions from the audience. There are already few in the chat, and I'll start reading them. So this one is from David Foster. What are the industry or academic-led AI ethics group projects that need more representation from consumer perspective? If you have any insights into that.
Oh, that's a pointed question. And I am not going to name names, but I will say that I'll give some general pointers here.
Wait, we have to say hey to David, because I think we've met him before at a conference. Yes, Dave, I'm looking at your face.
So here's what I'm going to say. If you have a code of conduct primarily driven by a company that is creating the product, and the code of conduct is to evaluate or regulate that product, we don't have effective representation that is free from conflict of interest. And again, we need to pull away from, those structural fox guarding the hen house approaches where it's like not actually rights or rules, but more like guidelines. If you ever watched Pirates of the Caribbean, they'd be more like guidelines that we can follow. We do need guidelines. Absolutely. We need best practices, case studies, codes of conduct, and we have to give ourselves space to learn in a real environment, understanding that local settings are going to provide us the data of improvement of outcomes. Local hospitals with limited resources are going to need to be on the front lines in partnership with patient communities. But, back to your question, I would say, I'm not going to name names. I'm just going to say, if you are, let's say, appointing somebody from a big tech company to represent your patient advisory board, and you have no actual patients when you're speaking about fairness and ethics, you're already off to the wrong start. And I don't know if you have much credibility in the first place based on, the starting point or the approach. And if that's the way you started, there's always a way to change course, and we are here to help.
Awesome. Thank you so much. This question is from Smith Patel. One of the challenges we hear regularly from developers is we don't know how to engage patients, include them in our process for product development. Do you have any recommendations for AI developers on how can they engage patients, especially in research or product development? Where should they start? You sort of answered that question, gave us the PCORI homework. We talked a lot about how health systems can do that. How would developers or early stage startups do this work?
Absolutely. So I'm going to start with the first step is to go find a grant for patient engagement. And PCORI doesn't just have resources, they have grants and funding. So there's another great organization out there called ARPA-H, but this step one would be, as you are building out your grant, think about a patient organization that is going to be independent and can maintain their editorial voice or their independent voice. We're not interested in creating conflicts of interest for patients, where in the past other waves, we've seen a lot of pharma backing patient communities. And in some ways that's good for clinical trials. We have to do that. But in other ways, it can create those structural conflicts of interest. So as much as you can, you got to go for that independent funding. We love Robert Wood Johnson Foundation, PCORI, of course, NIH. But start there, scope out, go to the organization or community-led group that has the right fit of expertise for your project. That's really going to be important. B, don't do what Valencia has experienced within our communities, which is don't just approach a patient community and say, hey, we want to recruit to your study. Then we've checked the engagement box. You have to bring them in early, often, and both sides are going to have to build capacity to engage with each other. That requires learning on behalf of the researchers and the patient community about AI. We have to create educational resources for both sides in order to build trust.
Thank you so much. Any other questions from the audience? Please feel free to unmute yourself and ask.
And Andrea, I want to add one final thing onto what you just said, because some of these companies have money, right? They may not need a grant. They just may need to find the right grassroots community organization to work with. But if you do have the money and you do have everything you need to get it started, it has to be people over profit. You really got to think about these people, each individual person, their lives, their medical condition, their families. We're losing a lot of people to cancer in general, but breast cancer specifically is what I work a lot with. And you got to think about the people, the community that these people are living in. And you can't just think, oh, well, we can do this and that. And we can be taught, we can learn the things right along with you. We can teach you a whole lot. You'd be amazed at how much a patient who has gone through cancer treatment, you'll be amazed at how much you can learn from us.
Yeah. Thank you. We have one other very, very good question from Dr. Ann Weibin. Curious about patient agency. For example, I know health systems where I get care, there's not a mechanism to opt out of my data being used in an aggregated way, including flowing through EHR vendors. What are your thoughts? Should patient be able to opt out, or at least be able to see all the way their data is being aggregated and processed?
So I think that in this current paradigm we have, okay, we've anonymized everything in research and therefore it's okay. But Eric Paraxlis, again, I'm going to point to one of his great studies and pieces on how that's a privacy placebo. And it's just too easy for us to join up these data sets. We proved some of this in our own research. And I think what we need to start doing is, let's stop talking about AI as like a monolith, just like patient communities aren't a monolith. It depends on the technology, the use of AI, the deployment within the community, context, and what the risks are. Like, people with medical devices are going to have a different set of risks than people with a genetic condition. And those people are going to have a different set of risks than the diversity within a community's health condition based on past harm, structural racism, disparities, and I could go on and on. But the key is, let's stop talking about AI and technology as a monolith. Like, we've got to get beyond that. And it depends on the community and the technology and how it's being used, how it's being deployed. The final thing is, if anybody wants to see our slides, I just want to let you know that keep in touch with us. We have 2 minutes left. I put our slides up on our blog. I want to invite you guys. We'll keep updates coming out in that June 26th town hall. We want to invite all of you to come. And with 1 minute left, thank you so much for having us.
Yeah, I see Alexandra's hand raised. So Alexandra, 1 minute left, but yeah, go ahead.
Just more gratitude. I am just so honored to just hear the advocacy and also, the importance of respecting the voices of communities and especially stakeholders that have direct impact. I think that ultimately that's the best way to do this work, to hear directly from folks. And I just wanted to shout out just this collaboration, because when I first talked to Mark, just really quickly, it was during the pandemic and it was around screening and being able to have the kind of ability to track symptoms, right? And so he was talking about that, and I was telling him, like, the community would love to get more support, get more resources, and community health workers empowering people to, be spokespersons for health, but also to grapple with the historical inequities that have happened and be able to have a voice. And so being able to set up community health worker programs was one of the things that Mark helped with. And I was like, I'm on board to support and to continue to see how this work can move forward with people who are committed to this cause in AI. Thank you.
Perfect note to end on. Thank you so much, everyone, for having us. We're honored to meet you and look forward to partnerships that may come about as a result. So thank you, and see you on the internet.